This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. It is my pleasure to introduce Dr. Arshed Quyyumi this morning. Dr. Quyyumi is a tenured professor of medicine, has been that for about 25 years here at Emory, and director of Emory Clinical Cardiovascular Research Institute. And he holds the Bruce Logue Endowed Chair for Cardiovascular Research. He is also a fellow of the Royal College of Medicine. As you probably heard, Dr. Quyyumi graduated from Guy's Hospital in medical school in London and did his internal medicine and cardiology training in London, followed by fellowship training at Mass General at Harvard, and then was the senior investigator and director of the cardiac cath labs at the cardiology branch of the NIH for several years before returning back to Emory, or before arriving to Emory. His research focus is that there's many. The breadth and depth of his research focus basically encompasses everything in cardiovascular medicine that I know. He's published over 600 manuscripts in peer-reviewed journals. Focus is clinical translational research in vascular biology, progenitor cells and cell therapy, cardiovascular genomics and metabolomics, mechanisms of myocardial ischemia and mental stress, health disparities, and cardiovascular risk in South Asians. And today he's going to talk to us about precision medicine trials and use of biomarkers in stratifying high-risk individuals. And I'll turn it over to you, Dr. Quyyumi. Thank you for volunteering this morning to do this.
Thank you very much. Thanks for the introduction, Pooja. What I'm planning to do today is to talk to you about two biomarkers, so you could call it a tale of two biomarkers. This is funding agencies, really no conflicts, except that some of the biomarkers I'm going to talk about today, the studies were funded by a grant from Abbott. So these are the two biomarkers I wanted to talk about. One is high-sense troponin that is commonly used. You probably use it almost every day in management of people. And then something that you don't use, which is SUPAR, or soluble urokinase plasminogen activator receptor, that you may not have ever heard of, but it's very important. And we're going to talk about these two. It is going to become available for measurement soon, we think. And then what happens with multiple biomarkers and prediction of disease risk. So let's take high-sense troponin to begin with. And I'm going to talk about its role and its, how it can be used potentially within the normal range of high-sense troponin levels. So I'm not going to talk about its role in diagnosis of acute coronary syndromes, which is well established, but I'm talking about high-sense troponin levels within the normal range that we are now able to measure. But start off with acute coronary syndrome just to remind ourselves that troponins were available many decades ago now as a test for myocardial infarction, and these assays became more and more sensitive. So there was, instead of just troponin, we are now using this very high sensitivity troponin measurement that allows us to measure the levels of troponin at a much lower level accurately. So what that allows you to do is to know whether there is an increase in troponin when a person presents with acute myocardial infarction at an earlier time point. So it reduces stays in emergency rooms and decision making, et cetera, et cetera. So this has been the development that has now allowed us to study troponin values even within the normal range, because the range is now much more extensive. So just to remind you what troponin is, it's a protein. It has multiple elements to it that you can see here. There's troponin I, troponin C, troponin T that is bound to the actin fibers in the myocardium. And what we are familiar with is what the levels are in the population. So this is a nice diagram, just shows the distribution of troponin levels in human beings. So this is thousands of people in the general population. So you measure this and then take the 99th percentile of what you find in healthy individuals and say that the top percentile would be an abnormal level. So anything below the 99th percentile in the general population is considered normal. And then the edge of it, so the top percentile, and that's considered elevated and abnormal. So these are the cutoffs that one generally uses to diagnose MI or suspicion of MI, whereas these would be considered normal troponin levels. But if you look at elevated troponin levels above that, so the so-called abnormal range, then understand that acute myocardial infarction, the type 1 MI, forms a small number of individuals relatively to all of the times that we are likely to see elevation of troponins. And we know this in your daily practices. There are many, many reasons like tachyarrhythmias, heart failure, hypertensive emergencies, myocarditis, Takotsubo, dissections, pulmonary embolism, and so the list goes on. There are many reasons why troponin may be elevated, so-called type 2 MI, and there is a whole series of 1, 2, 3, 4, 5 types of MIs that can lead to troponin rise above the normal range. But what I wanted to do largely is to remind ourselves that high-sense troponin levels, as a result of myocardial injury, it doesn't come from anywhere else, and that it is not specific for the mechanism of injury because there may be many. Now, not only is troponin bound to the actin filaments, but inside the myocardium, there is some free troponin T and troponin I molecules. So about 2 to 4% or 6 to 8% of I and T troponins are present in the cytosol. And if you injure the cell or make it ischemic or touch it even, then this cytosolic troponin will come out because it's loosely bound into the circulation, and that can be measured. And this is thought to be the reason why during myocardial ischemic episodes without infarction, you can still see elevation of high-sense troponin levels in the circulation, and that's where the value of this biomarker might be. So what we're going to talk about then again is the normal range of troponins. So what happens during myocardial ischemia? So there are a series of studies that have been done at Emory that have covered all these areas that I'm going to sort of summarize for you. Obviously, all of them are observational studies. So these are data now from studies that we had done called MIPS and MIMS, which were looking at, these were from NIH-funded grants, examining people with stable coronary artery disease who had a lot of tests, but they were also having stress during mental stress that was being measured. And what we did was to, in these two cohorts, separately measure troponin levels in people who had a positive stress test versus those who had a negative stress test. So the negative stress test people are shown in green and the positive stress test people are shown in red. And you see in both these cohorts, levels were higher in individuals who had ischemia. So resting troponin levels are high in patients with stress-induced ischemia. So even though the levels are being measured at rest, and this was reproduced by other groups as well. And then when we looked at the amount of troponin that was measured in the circulation of these people based on resting perfusion defects, because all of these people had SPECT scans, and with ischemic perfusion defects, and there was a relationship such that troponin levels were higher in people who had greater numbers or greater LV involvement with resting perfusion defects as well with ischemic perfusion defects. So, for example, for the lesson of this was that the magnitude of resting defects and stress-induced perfusion defects were associated with troponin levels independently. Then we asked the question as to whether there is a resting troponin level below which there is no likelihood of stress-induced ischemia. Could we develop a cutoff? So at the level of 2.5 picograms per ml of troponin, this is troponin I, measured using the Abbott assay, 95% sensitivity and a negative predictive value of 90% for not having any myocardial ischemia. And if you look for what happens with significant ischemia, then you almost get to 97% negative predictive value at the level of 2.5. So what is a level of 2.5? Almost one in eight people, one in seven, one in eight people who come to the emergency room with chest pain will have levels as low as 2.5. So you can say right away that they're very unlikely to have ischemia during stress testing. In fact, when we followed these people over this 3-year period, then no events occurred in people who presented with troponin levels that were low, below 2.5, but all the events occurred in individuals who had higher than that in terms of troponin levels. So very low troponin levels will rule out presence of significant ischemia in patients with coronary disease. These are people with stable coronary disease, of course. These are not people in the emergency rooms and so on, and is associated with excellent near-term prognosis. Now, could we predict adverse cardiovascular events, long-term outlook, based on troponin levels instead of stress testing? I mean, should that be a comparison since troponin levels are also telling us what's happening during stress-induced ischemia? So in this combined population, more than 800 individuals, 31% had a positive stress test because they also had stress testing performed as using nuclear imaging. And then the mean level was around 5. And then those individuals who had a positive stress test had higher troponin levels on average, like we said earlier. They were followed for almost 6 years, and there were lots of events that occurred. Now, if you look at the predictive value of stress testing, which is shown in the top right here in the cumulative incidence curves, then those individuals who had a positive stress test, which is shown in blue, had worse outcomes, as one would expect, but slightly worse. In fact, after adjustment, these individuals were no longer, the stress testing did not predict events after adjustment for clinical risk factors. But troponin level was a much better discriminator of risk. Look at people who had high troponin levels above median and low troponin levels. Vast difference, almost 3-fold higher incidence of major adverse cardiovascular events during the follow-up, and almost 8-fold increase in cardiovascular death in those who had high troponin levels versus low troponin levels. Not only that, but it improved the C statistic, meaning it reclassified risk. So perhaps a much better stress test, a much better test to look for ongoing ischemia is not a conventional nuclear stress test, but a high troponin level. So you can put all of this together and say that at low troponin levels, you identify patients with coronary disease who have very low likelihood of myocardial ischemia. High sense troponin levels elevated within the normal range is indicative of left ventricular dysfunction and stress-induced ischemia. And among the two tests designed to quantitate ischemia, troponin levels appear to be superior in predicting adverse cardiovascular events in the future in people with stable coronary disease compared to stress testing. Now, the next question was, what about troponin levels if we were to measure them also after exercise? So in the same study, in over 500 people who were having stress testing done, during physical stress, almost a third of them had a positive stress test, and we measured their troponin level immediately after the stress test as well. And notice that those people who had a positive stress test on the treadmill had, after 45 minutes of exercise, had higher troponin levels if they had a positive stress test. Those who had negative stress tests did not have an increase. Now, those who underwent pharmacological stress testing with regadenoson, nothing happened. There was no change in troponins. So what this tells us is that in those who are ischemic, during stress testing, there will be a rise in troponin. And in fact, this rise in troponin, these are people in red whose troponin increased by more than 20% after exercise. They had much worse prognosis, almost greater than 2-fold increased risk of MACE during follow-up. Now, if you combine that with resting troponin levels, then you get a much nicer delineation of risk. So those who had the highest risk were people who had a higher baseline troponin, again, all within the normal range, and who increased their troponin after exercise, they had a 4.5-fold increased risk compared to those who had low resting troponin levels, whose troponin level did not increase with exercise. So much better delineation of risk, once again, than usual stress testing, perhaps. And then if you had just one or the other, meaning a high troponin level at rest or only troponin increase during exercise, you had intermediate increase in risk. So high sense troponin elevation with exercise and higher levels of resting troponin levels predict adverse cardiovascular events beyond traditional risk factors and beyond inducible ischemia. So why do people have high resting troponin levels? Now, these are people with coronary disease that we're talking about, although this applies to the general population that we'll come to in a minute. So Daniel Gold here examined people who had CTOs and looked at their collateralization. So on the left, you see a person who's very well collateralized their right coronary artery, whereas poorly collateralizing the circumflex on the right there. So these collaterals were rated independently by largely by other people. I think Brian Kindia was the main person to do this. And what he found was that people with CTOs generally had higher troponin levels compared with equal adjusted individual with coronary disease without CTOs. But the higher ventrocollateral grade was associated with lower troponin levels. In other words, those who are likely to have ischemia because they are poorly collateralized also had higher troponin levels. And the corollary of that would be greater collateralization is associated with lower troponin levels. So higher troponin levels in people with coronary disease at rest is signifying ongoing ischemia, perhaps intermittent because troponin has a long half-life. So these silent ischemic episodes that individuals are getting during their normal daily activities leads to this slightly higher resting troponin level. Now, what about coronary artery disease severity? So this was addressed by the study by Amen some years ago, where we looked at almost 3,000 individuals and looked at their coronary angiographic severity of disease that you see on the left here. People with normal coronary angiograms had the lowest levels of troponin, and it steadily increased to people with non-obstructive disease, single, 2, 3 vessel disease, and similar difference on the right-hand side with Gensini scoring, which is a more accurate way of defining severity of coronary artery disease. And this was reproduced by other people. Here you see troponin levels increasing with a study by Laufer, the different ranges in men and women. But also importantly, they looked at CRP and NT-proBNP, and these were not related. So troponin levels are independent determinant for presence of CAD, and there was no relationship with other biomarkers like CRP and BNP. Then in the PROMISE trial, which was performed using CCTAs in almost 1,800 individuals, and then they had repeat CCTAs subsequently. But when they looked at the troponin levels in this population and their associations with CCTA characteristics, not only did they find that there was a relationship between the extent of coronary disease and stenosis severity, like we did, but they also found that it was associated with the presence of high-risk plaque. And once again, IL-6 and other things were not associated with the high-risk plaque as much as troponin was. Now, what about coronary artery disease progression? In our biobank cohort, almost 700 people had repeat coronary angiography for clinical reasons over the next 4-year period. And when you looked at individuals who had progression versus not, and on the right-hand side, you see quartiles of progression per year that we determine in the Gensini score, then the progression rate was 3.5-fold higher in those who had the highest troponin, who were in the highest troponin quartile at baseline compared to those lowest quartile. So once again, baseline troponin levels, very good predictor of progression of angiographic coronary disease. Now, what about prognosis? So what's happening to disease and plaque, et cetera, is of interest, and perhaps even ischemia is of interest. But what about long-term outcomes? So this is meta-analysis of 150 plus thousand people with coronary disease in 28 studies that have been followed. And essentially what this meta-analysis shows is that troponin is highly predictive, high-sense troponin in the general population, highly predictive of future adverse coronary events. Again, independent of all the risk factors and what have you. This is a study where we examined this in people with coronary disease who were undergoing cardiac catheterization. Some of them also had very little disease or normal. Over 3,000 individuals, lots of events during follow-up. And you see from the Kaplan-Meier curves that there is this gradation in risk based on circulating troponin levels that is easily discernible. So at a cutoff of around 5, there is almost a threefold increased risk in those who have below 5 versus those who are above 5. Now, this slide, we're looking at the interaction between coronary disease severity. On the bottom, you see from right to left, no disease versus three-vessel disease, and then increasing troponin levels going up this way. So if you look at individuals in the lowest troponin quartile, which is the blue line, blue set of bars, then you notice that if you go from no disease to three-vessel disease, there is a slight increase in risk. But if you go the other way from bottom to top of the slide, then for any individual group with any disease severity, the increasing troponin levels are determining their risk. So even without coronary disease that was angiographically visible, being in the highest troponin quartile, you had like a 4 or 5-fold increased risk of adverse cardiovascular events. The same is true with people with three-vessel disease. In fact, people with three-vessel disease with lowest troponin levels have similar outcomes as people with non-obstructive disease with low troponin levels. What about presence of CKD? As you know, in the floors, when you look at people with renal failure and high troponin levels, they say, oh, well, we can't interpret it. We don't know what it means because troponin levels go up with lowering of GFR. Well, here in the biobank study, we found out of the 5,000 individuals, 4,000 who didn't have CKD, but 1,000 had a GFR less than 60. And in fact, if you look at them separately, and the people on the left have no CKD, people on the right have CKD, notice that troponin is equally predictive, in fact, more strongly predictive of future adverse cardiovascular events in people with CKD than those without CKD. So it's not wise to ignore high troponin levels, even though it may be a type 2 MI you're dealing with in the hospital. But in the long term, individuals, even with CKD who have high troponin levels, will do worse than those who don't. What about heart failure? These are, again, 10 studies, 9,000 people. All of these patients are looked at on the left-hand side. Notice that people with high troponin levels, much worse outcomes, whether they had ischemic heart failure or non-ischemic heart failure. And then in this study, Krishan Patel looked at individuals with heart transplant who were having recurrent angiography for development of CAV, cardiac allograft vasculopathy. Again, a neat relationship between presence of CAV and troponins, almost 4-fold higher troponin levels in people who had CAV stage 3 or more. And in fact, the troponin levels are predictive of future death or retransplantation in this population. Once again, an independent predictor over all of the other measurements that are performed in this population. So the next question is, could we use high-sense troponin levels in decision-making for revascularization? So this was addressed by Daniel Gold in people who had CTOs in the cath lab who undergoing coronary angiography as part and were enrolled in the biobank study. So these people with CTOs generally had higher troponin levels than those who did not have CTOs. And the elevated troponin levels were associated with higher event rates, as we had seen previously. Now, so happened that 28% of these individuals with CTOs underwent revascularization. The rest didn't. And then when we looked at those who underwent revascularization, only patients who had median troponin levels that were high or troponin levels that were higher than median values were the ones who benefited from revascularization. In individuals who had low troponin levels, they had much better outcome anyway, and revascularization didn't appear to be of any benefit to them compared to those who were not revascularized. So this is an observational study. Obviously, this is not a randomized controlled trial. And there is still a lot of debate as to whether CTO revascularization actually improves outcomes in these people who are otherwise stable and not in the throes of an acute coronary syndrome. And clinical trials that have been randomized, that have not been conducted very well, but nevertheless they're out there, have not shown a benefit. And perhaps dividing these people by way of their troponin levels will identify a subgroup, a pretty large subgroup, who will actually benefit from revascularization. So patients with CTO and elevated troponin levels had better outcomes with revascularization compared to those who didn't have high troponin levels. And in those with low troponin levels, event rates were similar in those with and without CTO revascularization. So if you were to summarize all of this, because I've presented a lot of data, then we would say that higher troponin levels are higher in individuals with more severe coronary disease and those who are poorly collateralized, and they increase with transient ischemia. And the troponin levels are higher in patients with LV dysfunction and those who are likely to have inducible ischemia. Low levels, really low levels of troponin are indicative of low likelihood of inducible ischemia, that both resting and post-exercise troponin levels are independent predictors of outcomes in people with stable coronary artery disease. They are better at predicting long-term outcomes than stress testing in those with stable disease, that their higher levels are associated with faster progression of coronary disease, and that higher levels are independently associated with worse prognosis in many conditions, in the general population, those with stable disease, in those with heart failure, those with renal failure, and those with cardiac transplant. So wherever you look, it works. May identify patients with CTO who will benefit from revascularization. So we can think of several scenarios where you might want to actually investigate the role of troponin. So, for example, should we be using high-sense troponin levels first before deciding on stress testing? Should we intensify medical therapy in people with stable disease who happen to have higher troponin levels, or even look for occlusions to improve prognosis? Should we be using troponin levels instead of the things that we do for pre-op measurement of likelihood of stress-induced ischemia? As you know, about a quarter or a third of the stress testing that's done, nuclear stress test, is done in people waiting for renal transplant and other transplants, and then they wait 5 years before they get their transplant. Then you have no idea what to do with the stress test that was done many years ago. Should we not be relying on this? What about patients presenting with chest pain, even in the emergency room, who have low intermediate risk on evaluation and have very low troponin levels? Should they be discharged early? Following patients undergoing cardiotoxic chemotherapy, this is already being done. I haven't had time to get into that. Following up of patients with heart transplants for CAV risk. And then, of course, revascularization decision-making in people with CTO, but perhaps in everyone. Of course, just a reminder that a lot of our studies were done in people who are stable. They were not presenting with acute coronary syndromes or with chest pain in the emergency room. And they're observational, they're not clinical trials. And these are the clinical trials that you might want to launch into to even to establish the role of troponin in this setting. So our group is many fellows who are geniuses, have written many papers on the role of troponin in these various syndromes that I described, that I tried to summarize for you. So I now move on to the second biomarker, which is suPAR. So what on earth is suPAR? Well, if you've never heard of it, suPAR is soluble urokinase plasminogen activator receptor. It's a protein that is about the size of albumin, so it's pretty large. It's anchored to the cell surfaces of many cells. It's expressed on the immune cells, on the endothelium, smooth muscle cells, porocytes, which are in the kidney. It's a receptor for urokinase. It activates integrins and other elements inside the cell. But in terms of its cardiovascular potential or risk, it's been shown that circulating levels of urokinase plasminogen activator, so-called soluble urokinase plasminogen activator, suPAR, is able to activate monocytes into an atherogenic phenotype that may enhance progression of atherosclerosis and the rest of the syndromes that follow. So there are several experiments done, for example, using knockout mice, atherogenic mice, showing that if you knock out suPAR, the progression of plaque is much less, and so on. But I won't go into that for the sake of keeping you all awake. One more basic side, just to show you that's expressed on many cells. And when suPAR is released, it may have direct effects on neutrophils, on UPA and binding, angiogenesis, regulation of chemotaxis, and on podocyte injury as by itself. And this is data from Mendelian randomization study. So what is Mendelian randomization, or MR? Well, it's a statistical technique that can be used to decide whether a risk factor or whatever you're measuring, in this case, we're measuring suPAR, is actually causative of the disease. Because what it relies on are genetic variants where the level of this biomarker, in this case is suPAR, is elevated. Then you look at that population over time and ask whether that population is at a higher risk, like it's shown for suPAR. Coronary disease, myocardial infarction, peripheral arterial disease incidence was higher in individuals who were born with this missense variant, which allowed them to have lifelong higher levels of suPAR. So this helps to identify risk factors for disease. So now we are going from a biomarker to saying that it potentially is a risk factor, because when you are born with higher levels, it leads to higher levels of disease. So elevated levels of suPAR are indicative of chronic inflammation and of immune dysregulation. It's found in plasma serum, but all sorts of other body fluids. It's very stable. It doesn't go up with acute myocardial infarction, or if you have a bad tooth, or if you had a cabbage, like CRP does. Its concentration around 2,000 is thought to be healthy, and that's what it is in young people. Women have higher levels, and the levels go up as the renal function declines and as we age. In fact, if you age with this level, then you live forever. So how does it relate to cardiometabolic disease? And I'm going to run through this fairly quickly for you. So even with risk factors that we are familiar with, suPAR levels are higher in smokers, in hypertensive, if you're inactive, if you have dyslipidemia, etc. Increases with increasing ASCVD risk score in our predictive health cohort. It's higher in people who have carotid plaques, who have higher IMT, who have renal disease, who have higher CAC scores, who have lower microvascular dysfunction. How does it relate to coronary disease? So this was examined by a study by Danny Epen several years ago. And we found that suPAR levels are higher in individuals with coronary disease compared to those who didn't. And it was higher in those with more severe disease than those who had less severe disease. So there's that highly significant relationship with Gensini score. What about adverse event prediction? So this is data that Shaima has recently analyzed from over 40,000 people who were enrolled in the UK Biobank and who had measurement of Plower, which is a genetic proteomics-based suPAR measurement, a little different from measuring the way we do it, but nevertheless it's reflecting what's happening to suPAR in this very large population of otherwise healthy individuals without known history of coronary disease, mainly white, followed for about 14 years. And notice there is a wide separation based on suPAR level, which it was an independent predictor of outcome after adjusting for everything else, like blood pressure and diabetes, et cetera, et cetera. And it also significantly improved risk discrimination, meaning the C statistic improved. And you will say, well, wouldn't you have got the same results with CRP, which is also reflecting inflammation? The answer is no, it is independent of CRP. And notice that the people who had the worst outcomes in the red line are individuals who had higher CRP levels and higher suPAR level. And those who in green, who had the best risk, were people who had low levels of both. And if you had elevation only one of them, you were somewhere in the middle. So there's joint effect of both of these markers. We found similar results in MESA, where suPAR levels were higher and these are by quartiles. Again, an independent predictor of outcomes in the general population, multi-ethnic. And this, the effect of suPAR was not only independent of all the other risk factors, but also independent of CRP and troponin and BNP, and also of the CAC score. Now, what about people with stable coronary disease? This was addressed in more than 3,000 individuals by Danny Epen some years ago again, where higher suPAR levels were independently associated with worse outcomes, independent of CRP again. And then more recently, Addy looked at individuals who were survivors of breast cancer who are now more often dying from cardiovascular disease, and that could be predicted by the suPAR levels as well in the UK Biobank. Now, what about microvascular disease? So this was a study where we took 60 odd people and they had INOCA and chest pain without obstructive disease, underwent the usual coronary flow studies. And this is looking at coronary flow reserve, CFR. And on the right, you see all these measurements of the clinical risk factors that we did, including CRP and suPAR. And the only thing that correlated with microvascular dysfunction was suPAR levels. People with higher suPAR levels, worse microvascular function, not reflected by CRP or anything else in the clinical measurements of these individuals. In fact, when Ahmed Al-Badri followed these individuals over time, then suPAR was independently predictive of outcomes in this INOCA population, such that those who had higher than median levels of 2,500 had worse outcomes, almost 2.5-fold worse death and MI risk than those who didn't. So a couple of things to remember, that even this INOCA population is at risk of having worse outcomes over time, and it can be predicted. What about heart failure? This is looking at incident heart failure. So heart failure occurring in the general population over time in individuals who don't have heart failure to begin with. So this is 40,000 people from UK Biobank that Addy analyzed, showing that suPAR at baseline was highly predictive of subsequent development of heart failure over the next 13 years in this population. In fact, there is a straight line relationship in men and a sort of a curvilinear relationship with suPAR levels and incident heart failure in this population, again, independent of BNP. This is where we examined this with Salim several years ago in the Emory Biobank population. suPAR levels were higher in patients with heart failure, and then patients without known heart failure had a 4-fold higher risk of incident heart failure if they were in the highest quartile of SUPAR. And once again, independent of BNP. Generally, we use BNP levels to identify individuals who are going to have worsening of heart failure or development of heart failure. But in people without heart failure, the biomarker that predicted outcomes was actually SUPAR together with BNP. What if you do have heart failure? The showing on the left bar shows people without heart failure. On the right, it shows people with heart failure. Notice that SUPAR levels are higher in those who have heart failure. And on the left, you see that people with preserved EF and heart failure have lower levels than people with reduced EF. And people with ischemic heart failure had higher levels than those with non-ischemic heart failure you see in the middle bar, and that your NYHA class was higher with higher levels of SUPAR. So people with worse symptomatic heart failure had higher SUPAR levels. But most importantly, it's not just higher or lower, but it's highly predictive. So people in the highest quartile had 3 to 4-fold higher risk of all-cause death or cardiovascular death, independent again of all the other biomarkers like troponin and CRP and BNP and all the other risk factors and EF and everything else. And it predicts outcomes in HFpEF as well. This is data from TopCat, which was a large sort of MRA study, as you know. Peripheral arterial disease, SUPAR levels are 22% higher in people with peripheral arterial disease than those who just had coronary disease. And you see this graded increase in levels in people who had both CAD and PAD had much higher levels of SUPAR than people who had none. But if you had just CAD or just had PAD, you had intermediate levels. And also if you had PAD in many sites, you had higher levels of SUPAR. And then not only were the levels higher, but higher levels were more predictive of worse outcomes, cardiovascular outcomes, as well as leg outcomes in individuals with high SUPAR levels than those who didn't. So more amputations and death and revascularization rates for PAD. We all know that Lp(a) is an independent predictor of outcomes in CAD individuals. And here we looked at the biobank cohort and divided people by not just by Lp(a) levels, but by SUPAR. So the highest risk group, the red line, is those who have high SUPAR levels and high Lp(a) levels. The next one, the purple line, is individuals who had low Lp(a) levels, but high SUPAR levels. So a little different. But whether you had high or low Lp(a) levels, as long as you had low SUPAR levels, your risk was low. So a lot of the risk with Lp(a) is actually mediated through SUPAR. What about chronic renal disease? Remember, this is a biomarker that has been known to our nephrology colleagues for much longer than we have been aware of it, and we are still not aware of it. But it's now used. It has role, as I said, in podocytes in particular. Is associated with proteinuria, and it's used as a diagnostic test on biopsies for diagnosing FSGS. But we looked at this in people within our biobank to see whether chronic renal failure or renal deterioration over time was associated with SUPAR levels. So this is individuals divided into quartiles based on their SUPAR levels, and we are examining here change in GFR from baseline over the next several years. So notice that people who are in the highest quartile of SUPAR levels had the greatest or the fastest deterioration in their renal function over time compared to those in the lowest. Independent predictor of renal deterioration, other than creatinine, nothing else predicts renal deterioration like SUPAR does. And this is development of CKD in people who didn't have CKD to begin with. Those in the lowest quartile or lowest two quartiles had the lowest risk, whereas those in the highest quartile had the highest risk of developing CKD over time. In fact, looking at acute kidney injury, so these were we looked at individuals who were going through the cath lab and getting a load of dye or contrast, which, as you know, can sometimes lead to renal injury. So we measured renal injury, increase in creatinine by 50% in people who had just undergone cardiac cath in the biobank, and found about 8% did, and that we could predict who these people would be based on their baseline suPAR levels. So people in the highest quartile suPAR levels had a fourfold increased risk of developing acute kidney injury after exposure to contrast than those who didn't. Kind of a simple test that one could do to avoid contrast in this population, perhaps. Now, what about other cardiometabolic conditions like liver disease and diabetes? So in this study, Shaima examined suPAR levels in diabetics and non-diabetics and found that they were 16% higher in diabetics. And we know that diabetes leads to higher event rates, so almost 60% increased risk in diabetics compared to non-diabetics, also in our biobank cohort. But when we divided this up by suPAR levels and asked the question as to how there is interaction between them, then notice that the highest risk group are those people who had diabetes and high suPAR levels. The second highest risk group is people without diabetes and high suPAR levels. But if you have diabetes and have normal suPAR levels or have no diabetes, it doesn't matter. 50% of risk, more than 50% of risk, is mediated by suPAR in diabetes, whereas CRP mediates less than 1% of the risk in diabetics of future cardiovascular events. So much of the risk from diabetes to future cardiovascular events is being mediated through chronic inflammation and immune dysregulation that can be identified by suPAR levels. What about liver disease? This is a study that VJ did, again in the MCAP population, identified people with advanced hepatic fibrosis or AHF that can be done by this formula called FIB4, which correlates extremely well with imaging modalities that look for liver fibrosis as well. What he found was that both suPAR and CRP are elevated in this population, and that if you have AHF, then you have worse outcomes. But 47% of the risk in individuals with AHF is mediated through suPAR, but not CRP. What about psychosocial determinants? Now, we know that psychological health and social determinants are extremely important in determining outcomes. And when we think about these factors, we think that is because of availability of healthcare or non-compliance or and all of those kinds of factors. But in this study, David Fuller, who's a medical student in Germany who came here to spend summer and was very interested in social determinants, asked the question whether educational level, which we know is an independent determinant of outcomes, was associated with suPAR levels, and there was almost a linear relationship. So that suPAR levels were almost 20% lower in people who had graduate level education or above versus those who only received elementary school education. Again, independent of everything else. And when you look at modification of the risk of cardiovascular death based on educational level, which is independently predictive, almost 40% higher risk, then when you adjust for CRP, nothing happens. But when you adjust for suPAR in Model 3, it disappears, the risk from education, suggesting that almost 50%, almost half of the impact of lower educational level on adverse outcomes is mediated through suPAR levels or mediated through chronic inflammation and immune dysregulation, which is not reflected by CRP levels. What about other psychosocial risks? So there are now studies that are longitudinal that have looked at adolescent risk for major depressive disorder, which was positively associated with suPAR levels, but not by CRP. Children who experience more advanced adverse childhood events, such as low IQ states, poor self-control, socioeconomic disadvantage, had a higher elevation of SUPAR levels as adults. Childhood and early adulthood social isolation and loneliness, which we know are risk factors for outcomes for all diseases, but particularly for cardiovascular disease, was associated with higher SUPAR in adulthood. Exposure to racial discrimination in the younger age was associated with higher SUPAR levels and higher levels of sleep problems, etc., at the age of 30. And SUPAR levels are associated with higher incidence of PTSD as well. What about aging? I will stop pretty soon. But notice that when a pace of aging was measured in this study, and I won't go into the details, but nevertheless is reflected by SUPAR levels. Even facial aging, when measured, SUPAR level was measured at 45, but facial aging was measured at 45, SUPAR levels measured at 37, so 7 years earlier. You age faster, even the way we look. So accelerated aging, cognitive decline were associated with elevated SUPAR levels. And in this longitudinal study, non-smoking status, greater physical activity was associated with lower SUPAR levels. It's hard to cover everything that this measure of chronic inflammation and immune dysregulation does. We've talked about some of these diseases, but it's a huge role in infectious diseases and cancer as well that we want to address now. And there are several therapeutic strategies that are being investigated. There are monoclonal antibody clinical trials going on to suppress this pathway, particularly in cancer, but also in renal disease that are currently being investigated. But as far as we know for now, smoking cessation, increased physical activity, and changing the diet into a healthy and absence of social determinants of health are associated with lower SUPAR levels. However, standard anti-atherosclerotic therapies that we use, like statins, etc., actually do not influence SUPAR levels. Now, what about using both troponin and SUPAR together? So this is just showing you Kaplan-Meier curves of cumulative incidence survival of people with where we use both of these markers divided by median levels to show that they're additive. So you can get better discrimination of risk by actually adding both of these markers together, whether we are looking at people with coronary artery disease or those with chest pain or normal coronary arteries. So what we have done now to address this whole issue, where we have realized the importance of these biomarkers and these pathways in reducing risk, is to look at these 4 biomarkers, high-sense CRP, troponin, SUPAR, and BNP, as a biomarker risk score, because they're all additive in terms of prognosis in these individuals. And we have now designed this precision CAD trial that I have talked about previously, but this is just a reminder with the premise that conventional therapeutic approach recommends use of similar drugs at similar doses in all individuals. The precision approach would be to have a more personalized, patient-centric approach using guidance from these multi-marker risk scores, because these biomarkers not only identify high-risk individuals, but also low-risk individuals that do not need intervention. And we also know that these biomarkers are modifiable by lifestyle intervention and anti-atherosclerotic therapies. So this trial is now examining people with stable coronary disease without heart failure, measure 4 biomarkers. If they have elevation of 1 or more, they get randomized into an optimization group where we optimize their medical and lifestyle therapies. And then the others just undergo usual care. And then we will look for modification of the biomarkers to begin with, and then to subsequent adverse cardiovascular events in the future. The study has stopped recruiting. We've recruited more than 250 people and should have the biomarker results from 6 months levels available in about 2 to 3 months. So that's something to look forward to. Our group has published many, many articles on SUPAR as well that you, if you're interested, can look up. Um, and um, and all this work is actually due to all these amazing fellows and residents and our lab members who make all of this possible and do all the work. I just take the privilege of presenting it to you and our collaborators around Emory and outside, and of course our funding agencies who allow this work to occur. Thank you very much for your attention.
Thank you, Dr. Quyyumi, for a very comprehensive review of 2 biomarkers. And congratulations for all this work and ECRI papers. Look forward to the results of the Precision CAD trial in 6 months, you said, right? So, okay, I'm going to open it up for questions. Please type in your questions in the chat.
Pooja, this is Tanvir. I have a question
Yes.
for Arshed. Good morning. Thank you for that very nice, extensive review, Arshed. The problem is these things are very good and identify people who need for the evaluation. But when patients present for different disease states in the emergency room will, for some reason or the other, draw troponins, everybody. It makes it very hard to distinguish which set of patients can be worked up as outpatient and which really need hospitalization. So that this opens up a whole field where the discrimination is not there, and that begets the problem of extensive length of stay and admission of every patient to the hospital system, and overloads our system. So it is great that we know where the pathway that we need to take for these patients, but acute care is greatly affected when people show up in the emergency room and have positive values of these results. So would you suggest how better to stratify that index, which is very important for our care of patients?
Yeah, it's a great question, Tanvir. As I said right at the beginning, talking about troponins, that I am not talking about acute coronary syndromes and people presenting the acute in the emergency room. This has nothing to do with that group. These are people with stable disease or no disease. These are people you see in clinic and not in the emergency room. Now, whether we can use some of these cutoffs that I was referring to in the emergency room or not will have to be tested. But really, it's that population that was not studied in these areas that I showed, because that's sort of fairly well established, right? What troponin level makes you admit and what have you. It may be a lot of people, but nevertheless, it's not being addressed by at least what I was talking about. It's more to do with how you manage people in clinic.
No, understood. I did not mean ACS patients, but when people do random battery tests and find these abnormal results, that becomes a problem.
Yeah, well, but then you have to look down the list of things that I was saying. For example, if you have somebody with renal disease and they have a high level, and we say, oh, it's because clearance is affected, so that's what it is. But actually, it is going to be significantly determining their outcomes over time, and something needs to be done for their cardiovascular risk, and not just say, oh, well, it's somebody with renal disease and it's not going to affect their outcome. It is, and so on. So those random numbers can be prognostic. We just don't use them as such. And we are hoping that SUPAR will become available in about 3 months or so. At least it'll be approved by FDA. They're expecting to. And then hopefully one would be able to even measure it.
So, Dr. Quyyumi, there's a comment in the chat from Dr. Balk. Is the calcium score additive or not to the biomarker risk score?
So the biomarker risk score is independent of CAC. So people with CAC, it's predictive. People without CAC, it's predictive. So it's additive, and it predicts future development of CAC, it seems. So these are, the way I look at it is these are biological processes that are enhancing or accelerating or causing disease that we are trying to treat. If you don't have plaque, it'll lead to plaque. If you have plaque, it'll make it more unstable. And that's what they are reflecting. They're just reflecting the processes that are going on in our body that we are unable to test We cannot be looking for vulnerable plaque every month or every 6 months by imaging them. But these biomarkers are telling you the activity in these areas that would be subsequently of risk for them. Easy to measure, cost almost nothing, and that's why nobody uses them, because they don't make money for anybody. But they are highly predictive. But it'll require trials like the one that we are doing in order to convince the community that this is actually a way to go.
So, Arshed, Spencer here. This precision trial is very exciting, but you're looking for endpoints of clinical events. Is that true?
It's a small study, Spencer, so we had powered it only to look for improvement in biomarker risk score. So
yeah, it's. I was going to say it's 250 seem very small for. What's the plan toward a really large scale trial of this sort? Because these are incredibly powerful predictors, and it seems like we need clinical events in a trial.
So we have and others have looked at retrospectively large clinical trials that have events, that had biomarkers measured at baseline, had biomarkers measured after a year. For example, we did this in Barry 2D to show that when you improve this risk score, the biomarker risk score, you have better outcomes. And how did you get there? Just by merely optimizing therapies.
Yeah, I remember that in Barry 2D, but it's not found its way into practice. And as you point out, everybody, it seems like everybody is evaluated somehow, whether they have, they worry about coronary disease, they worry about heart disease. And so everybody gets the workup. And what do they get? They get stress tests and all these things that are not very predictive. and you've got a highly powerful thing. How does this move into practice is what I'm saying.
Well, this is the reason for doing the precision CAD study, is to see whether we can offer this information to the physician, the cardiologist, and the patient, and tell them, you're at high risk based on this. Do something about it. And so what they do is to optimize the therapy. You think everybody's optimized that you're seeing in clinic? Less than 30% are. You can always do something, and if nothing else, you can add colchicine. And so it goes. You can lower LDL from 69 to 49 to 39. There's always something to be done. So we managed to optimize most of these individuals. So we will see whether just using usual guideline-based therapies and offering this information of high risk in an otherwise stable individual will allow people to be more optimized. And that will not, first of all, normalize their biomarker risk score, which is tantamount to saying that their risk has improved, but then also to follow them long term to show that they actually have improved risk. And so that's a purpose in it. So I think the way I see it is that this will be, if we are successful to show that the biomarker risk score is improved, then this will lead to a much larger event-based trial that somebody will have to pay for, that would then make this, take it to like what you said, which is in clinical practice, because
it's got to get the guidelines
trial
eventually. Yeah,
exactly. To change guidelines, you need those trials, and even all those areas where I thought that high-sense troponin could be useful. We need a clinical trial for each of those situations where you use troponin level versus usual care to identify people and randomize them to the two types of care, and then show that this actually improves outcomes. And so there were 7 ideas there, for example.
Yeah, we have one last comment here by Dr. Wilson in the chat. Should treadmill testing move to measure these advanced markers after stress testing?
Yeah, that would be my suggestion, is to, instead of injecting with radioactivity, just measure troponin level after stress test. You'll get much better information.
Okay, thank you, everyone. In the interest of time, I'm going to close. Thank you again, Dr. Quyyumi. Wonderful presentation, and thank you for the time this morning, everybody. Don't forget to get your CME, and I'll see everyone next week.
The preceding program is copyrighted by Emory University.